Oh, I understand. So I do have a disclosure with cornea. So do you see the second slide?
Yes, we see it.
Perfect. Okay. So first of all, I will start with the guidelines because it's always important to look back at the guidelines. And since 2014, the guidelines recommend for valve repair or valve sparing. The term we used was valve repair, and I think it was a good term, using either the reimplantation technique or remodeling with aortic annuloplasty technique in young patients with root dilation and tricuspid valve, when performed by experienced surgeon. And this was again the same story in 2017. In 2021, the guidelines somehow were more vague because they used for the same indications aortic root or tubular ascending aorta, irrespective of the severity of AI. So, which mean all dystrophic aneurysms, whatever the degree of AI. They recommend valve sparing root replacement. So, more vague, less technical, because before it was reimplantation or remodeling with aortic annuloplasty. So they recommend as a class 1 indication they recommend as a class 1 indication for any type of valve, actually, bicuspid or tricuspid with root dilation, and introduced as well a 2B indications for valve repair, which was not very clear, but we can suppose that it's related to isolated AI. So if we clearly read the guidelines, if the valve is repairable, tricuspid, bicuspid, unicuspid, or quadricuspid, irrespective of the degree of AI, with or without aneurysms, they're a potential candidate for repair. However, the reality is completely different. And it's always very important to nuance the scientific debate and the talks of all the experts and the reality of what is happening. STS database, it's not actually 17%, I should correct that, it's 13%, 1-3, valve sparing procedure, and Bentall, 87%. So it's very few. Urology survey, it's 22% valve repair, and I had all my patients from my center, so this might have been increased as it is a small group. However, aortic valve replacement in the young represent an excess mortality with 30% death rate. When you have a bioprosthesis at the age of 45 to 54 years old, this is New England paper, 26% if you have a mechanical valve death rate at this same age. If you have a bioprosthetic valve at the age of 40, you will lose 20 years of life expectancy and you have a very high risk of being reoperated. In our series, we have a repair rate of 77.4% rate with or without aneurysms, so almost 80%, with 92% survival at 12 years, similar to general population, and a low risk of reoperation at 12 years. So in other words, the goal is not to repair the valve. We know we can do it, and thanks to from Tyrone David and Jakub and others, Jibrin El-Koui, Jochen Schäfers, and all the surgeons that pioneered, and Michael Borger is one of them, who pioneered that field of aortic valve repair. But the goal is to repair all repairable valve, and that's the challenge because STS database in 2021 is 13% repair rate. So here is the possibility to standardize a physiological approach of aortic valve repair. You all know the remodeling technique that was brought by Jakub, as well by Tyrone David. But the principle was to have a very physiological root reconstruction with 3 neosinuses of Valsalva that treat the dilation of the sinotubular junction, but doesn't address the annulus dilation. And the other technique brought by Tyrone David was the reimplantation technique, which include the valve within the tube to the detriment of valve dynamics, particularly with straight tube, but it could be standardized by remodeling with an aortic annuloplasty. So combining the two approaches, taking what is good in both and adding to the physiological root remodeling an expandable aortic ring annuloplasty. The ring has been designed to be expandable in order to mimic natural dynamics, and the standardization is based on the measurements of the annulus. So if you have, for example, 29 annulus, which is the mean aortic annulus in dystrophic aneurysms, you will use a 27 ring and a 28 graft. The ring has been designed to have 10% systolic expansibility, like in normal root and annulus dynamics. So here is the first example with an aneurysm with a tricuspid valve, big regurg with a large jet eccentric towards the mitral, and pliable valves with a dilation of the aortic annulus. Keep in mind that the annulus, which is measured with the echo, is always underestimated. So if you have 25 with the echo, you will have 29 with EGAR. You dissect the cervical plane first, and it's very important because you need to reach the cervical plane. You remove the roof of the aortic wall and keep 3 to 5 millimeter of aortic wall along the leaflet insertion line. You dissect the cervical plane deep below the left main up to the septum, and then here at the level of the infundibulum, you will dissect very close to the aorta. There is very often a fatty plane, particularly on tricuspid valves, and at the level of the membranous septum, which is the area where you cannot go as low as you wanted, you will dissect with scissors to prevent lesion of the membranous septum and the bundle of East. We'll put stitches in the cervical plane, one below the nadir of each cusp, one below each commissure, and at the level of the membranous septum, we put the stitch externally in order to avoid the bundle of East and the membranous septum lesion. Then the first step is to line up the free edges. What is very important in this kind of surgery is to go stepwise. And here you will line up the free edges. A couple millimeter is an excess of length on a tricuspid valve, and you want to have symmetrical free edge lengths on the three cusps. Then we will reconstruct the valve with 3 symmetrical sinuses using the remodeling technique. We start down below the nadir of each cusp and at the nadir, and then restart from the commissure and have a root reconstruction, which is symmetrical. And then we will assess the effective height using Schaefer's caliper that you may I don't know if you use it, if you're familiar with it, but it is very important to use it in order to have a systematic assessment of cusp effective height that you can do with 3D echo and do with the caliper, and you want to have 9 millimeter on the 3 cusp. You see that this valve had symmetrical length on the leaflet, but the geometric height of the right is lower, which is consistent with the echo that we had with the jet eccentric towards the mitral. And then at the end of the procedure, you will tie the ring, which is the last step, like you will do for the mitral. The last step is to tie the ring, and this will increase the surface of coaptation and protect the repair. So the stitches around the ring, so that ease the asymmetrical positioning of the stitches and allow the placement of the stitch the lowest as possible. And then we will do the echo control with a trivial jet and a good assessment of you see the plication on an audio variantius, and you can assess as well the effective height of the cusp. So why do I favor the remodeling and ring? When you do the reimplantation, you start with the annuloplasty. Then you do the roots, and very quickly comes the question on how high do I place the commissure? How do I place them circumferentially? How do I pull on the graft? If I use Valsalva graft, how do I manage to have a fixed neo-sinotubular junction while the commissure may not be at the same level or seems to be at different level? And most of the time, the repair will be eyeball, and as a result, the patients are highly selected. With very few patients with significant AI, most of the cases have either no regurg, grade 1 or grade 2 central, but as soon as there is a significant regurg, most of the time they undergo bento, which is consistent with the STS database from 2021 with 13% valve sparing rate and Eurorod survey 22%. When we do the remodeling plus ring, we start with the leaflet length. We do the roots, placing the 3 commissure at the same level, placing them circumferentially. There is no question on where do I place them. They will follow the graft. They will be resuspended by the graft. Then you assess the effective height on a... You hear me, or is that okay?
Yes, yes, we hear you perfectly.
Okay, because I had a mic on I heard a mic. So then you assess the effective height on an untouched aortic annulus, and at the end of the procedure, you do the annuloplasty. So this standardized approach allows to increase the rate of repair. So the question is not an opposition of technique. The question is the standardization to increase the rate of repair. Of course, the replantation technique is an excellent technique because it addressed the annulus and the sinotubular junction, and I would never recommend to do the remodeling alone, which does not address the annulus. But the combination of remodeling with ring, with the standardization and the simplification of root reconstruction in a symmetrical manner, help to increase the rate of repair and tackle the 80% repaired valve. And the last thing, the last argument is that in case of failure, where actually most of the time I tend to re-repair, but if you don't have the experience, it might be tricky, and sometimes you need to convert for valve replacement. If you need to convert, you remove the ring, and then you place a big valve. If you have the proximal suture of the reimplantation, or you remove everything and then do a bento, but that's another big journey that the heart may not and the patients may not support, or you put a small valve, which is a concern. The other thing is the bicuspid valve, because the remodeling technique is very, very helpful to address the remodeling, the bicuspid valve. And here is a perfect example. It was a young sport gentleman with an asymmetrical angle, an eccentric jet with a prolapse of the fuse cusp, a dilation of the annulus of 34, and a very big prolapse of the valve, of the non-fuse cusp. Dissection is similar. With the it is very important to dissect the subvalvular plane, and very important, particularly at the septum area between the commissure between the right and non-commissure, between the right and left commissure, sorry. At the level of the infundibulum, you will also dissect very close to the aorta and reach as low as you can at the level of the membranous septum and at the level of the infundibulum. You place 6 stitches, 1 below each commissure, 1 below the nadir of each cusp, and at the level of the membranous septum, you place the stitch externally to avoid the bundle of V's. Then you line up the free edges of the cusp, and it's easy because you have only one line of coaptation, and you plaque it at the level of the raphe or resect at the level of the raphe if needed. So it's easy to do. Then you will reconstruct the roots, this time not with 3 symmetrical tongue as a tricuspid valve, but with 2 symmetrical tongue, placing the commissure at 180 degree. And again, the commissure will be at the same level. They will be placed at 180 degree. So they will follow the graft, and the valve will become symmetric, which is the base of stable bicuspid repair. And then you will assess the effective height. If needed, you may resuspend the non-fused cusp. I tend with time to resuspend very rarely the non-fused cusp now in order to preserve long-term valve opening of the valve. And then you tie the ring, placing the stitches around the ring in order to accommodate asymmetry. This is particularly important for a bicuspid valve because it allows it allows it accommodates the asymmetry of placement of the valve. And then so you see the nice coaptation of the valve and a nice opening of the valve. Another interesting part of the remodeling technique is that in case of ascending aorta aneurysms with BAV, right-left fusion and sinus of Valsalva less than 45 millimeter, with coronary ostia that are below the sinotubular junction, so non-dilated right-left sinus, but a large dilation of the non-fused cusp sinus, then you can do an EMI remodeling. And here it's also one of the interesting part to tailor your operation to the patients and not always use the same operation. Here you can dissect the roots. You will dissect in between the pulmonary and the aorta, reaching the subvalvular plane. You open the roof of the tail sinus to see nicely, so you free the pulmonary artery, and you see now arriving the left main. And so you do that under direct vision, under control, and you go below the left main with a right angle, and you can remove that non-coronary sinus that is very dilated. You see that the right and left sinus are preserved with coronary ostia below the sinotubular junction, so you don't need to replace them. And then you place you place annular stitches below the nadir of each cusp, like you would do for an aneurysm, and the one at the membranous septum externally. And then you line up the free edges of the cusp as you would have done if the coronaries would have been detached. So that's an easy part with the removal of the non-coronary sinus. You plicate the central part or resect if needed. And that's the then in case the commissural angle is not 180 degree, you can plicate that sinus like Schaeffer's has described many years ago, showing that the plication of the sinus improve the quality of the results because you're making the valve more symmetric. So the combination of the EMI remodeling and the plication of that fused sinus with the at the level of the raphe, you put 2 pledgeted suture, 2 stitches, and that will plicate and improve the angle of between the 2 commissure towards 180 degree. As soon as you have done that plication of the sinus, you can do the root reconstruction with a graft that you will scallop as for a root aneurysm with 2 symmetrical sinus, but you remove 1. And that sinus will allows you to reconstruct the non-coronary sinus, but also will help to make the valve symmetric and put the commissure at 180 degree with with the commissure who will follow the graft. and that's very helpful. And then you will, after resuspend the effective height with the caliper and assess. You see that the effective height is at 9 mm, which is almost constantly the case. So you can keep all the free edge lengths of the non-fused cusp. This is also the interesting part of the symmetrical design of the repair, placing the commissure at 180 degree, because that will automatically lift up the free edge of the non-fused cusp. And here I used an open ring because I don't have yet the open ring for isolated AI or tubular aorta replacements, where you haven't detached the coronaries. You go underneath the coronaries, both coronaries, and tie it down in the subvalvular position in order to reduce the aortic annulus, so address the dilated aortic annulus. This will increase the surface of coaptation and protect the repair. This is always the same principle. And of course, you do the echo control at the end, and you see the nice sinus reconstruction of the non-coronary sinus and the coaptation of 5 mm, an effective height of 9, and I guess there is a gradient, which is most of the time an angle that is close to 180 degree and a mean gradient of 8. In case of isolated AI, I'm just looking at the time. Is that okay for the timing?
Yes, yes, please go ahead. Yeah.
For isolated AI, the idea is to restore the ratio between the sinotubular junction and the annulus around 1.2. So in other words, is to treat the dilation of the sinotubular junction and to treat the annulus. You may be familiar with the Cabral stitch, which described in 1966 the subvalvular stitches and supravalvular annuloplasty. So he had already intuitively understood that there is a need to address both functional diameter of the aorta. But we know from now on that isolated subcommissural annuloplasty doesn't work. They will redilate, and they are a risk factor of reoperation after repair. So we describe in 203 the concept of double annuloplasty, which is the equivalent of a reimplantation or remodeling with annuloplasty without replacing the root and without detaching the coronaries. Schaefer's described the suture annuloplasty stitch, and there is the internal rigid ring described by Rankin. So both address the annulus, but the pulse doesn't go all the way up to the sinotubular junction in the internal ring. Here, of course, it doesn't address the sinotubular junction. And there was similar concept brought by Fatouche with homemade Dacron ring with internal and external, which are similar concept to address both dilated diameter. Indeed, it is very important to address the dilation of the annulus and the sinotubular junction in isolated aortic valve repair. We published that. It's actually published now since 2020 with a higher reoperation rate if you do single annuloplasty compared to double annuloplasty, and similarly for isolated AI. So an additional STG ring is a protector factor for reoperation and residual AI compared to single annuloplasty. Standardization is similar to an aneurysms based on the aortic diameter, and we will address, for example, here it's a typical case of a bicuspid repair with an isolated regurg. You see that the root is not dilated, the annulus is dilated, the jet is eccentric towards the mitral, and the angle is asymmetric around 150, and we will we'll transect the aorta above the sinotubular junction, of course, assess the valve at the level of the raphe, measured the geometric height. You need to have more than 20 millimeter for each cusp. And you see that the annulus is very large, 30 millimeter. You will dissect the subvalvular plane, cutting the aortopulmonary ligament between the pulmonary and the aorta, free the space below the left main, free the space below the right, and then put suture below the nadir of each cusp and below each commissure, like for an aneurysm, except at the level of the membranous septum, where you will where you will put the stitch externally. And then you will line up the free edges. It's always the same principle. When you do an isolated AI, it's a little bit more tricky because you haven't detached the coronaries, so you have still the roots in place and the sinotubular junction in place. So you have to go hemicusp by hemicusp, but this is the same principle. You line up the free edges on the free edge of the non-fused cusp, and then you will plicate the fuse sinus between the right and left in order to improve the commissural angle, as we did previously for the ME remodeling. This will help the commissure to be towards 180 degree, and you use two plageted suture, like Schaefer's described a few years ago, and this will improve. He was doing it from inside. I prefer to do it from outside in order to have no interference with the valve, and no interference inside the aorta, no protrusion inside the aorta, and then you'll put the STJ stitch. So if it would have been an aneurysm, we would have done a remodeling. In case of a supracoronary aneurysm, we would have done an ME remodeling. But here there is no ascending aorta dilation, so we put the sinotubular junction ring, so the corneal ring, which is expansible, we'll place it, placing the commissure at 180 degree, and the combination of the ring with commissural placement at 180 degree and the plication of the sinus help to make the valve symmetric. And then we assess the effective height. Only if needed, resuspend the effective height and try to avoid the effective height resuspension of the non-fused cusp, and then address the annulus dilation with an open band, which is placed below the coronaries and tight in the non-coronary sinus in order to increase the surface of coaptation and protect the repair, and then you will close the transection of the aorta. Not this is a very standardized in that way to address both the level of the sinotubular junction and the annulus, and of course do the echo control at the end in order to, you see that the valve is very symmetric now, and and of course check all the parameter with the effective height and the gradient. So it's possible to standardize aortic valve repair according to the aorta phenotype. With root pathology, you will do remodeling with annuloplasty. With descending aorta, we will need do supracoronary aneurysm and annuloplasty if needed, plus minus replacement of the non-coronary sinus, and double annuloplasty for isolated AI. And by that way, you can repair 80% of AI cases. We have done on a multicentric manner more than 1,200 patients, and we're doing another extraction, so we have more than 1,500 now, with a low mortality. In France, there was a comparative multicentric trial comparing remodeling with ring versus mechanical Bentel, and at 4 years, we already had a reduction of valve-related death and reduction of major adverse valve-related events. This was published last year, and we had a 92% freedom survival, similar to the general population for bicuspid and tricuspid valve, and there was no difference for phenotype, and the rate of repair was less than 6 to 7% for bicuspid or tricuspid valve. Fenestration was not a risk factor, either respected or fixed. which most of the time is an argument to replace the valve in many centers. A respective fenestration is not a risk factor, and you fix it either. So that's good to know. And the pericardial patch, if this technique is standardized, is not a risk factor. It was an increased risk of patch dehiscence at the time of the operation within the hospitalization stay, but afterwards, after the patients get out of the hospital, it's not anymore a risk factor of reoperation. It's not significant. For bicuspid valve, we have a rate of repair of 80% as well, and published again that if you address both the ratio, the sinus-tubular junction and the annulus by a double annuloplasty, an hemi-remodeling with an annuloplasty, or remodeling with annuloplasty, you have better results with less than 3% re-op at 9 years compared to single annuloplasty. With a 22% rate of reoperation. We also look at the remodeling route, comparing a calibrated extra-aortic ring compared to homemade ring, and we show a difference in terms of reoperations and recurrence of AI with freedom from re-op in case of a calibrated expansible aortic ring of 98% versus versus almost 10% if you have a Dacron ring, probably because the Dacron dilates as well, and also because the technique was maybe less standardized when we introduced the technique. But the calibration of a device made for it seems to be more stable than a homemade Dacron ring, which makes sense. So in conclusion, the current mechanical and bioprosthetic valves are palliative treatments that reduce life expectancy, and I think it's very important to keep that in mind when we make decisions, and which should be as much as possible shared decision with the patients. Standardizations of valve repair with an extra-aortic ring annuloplasty allowed an 80% repairability rate with similar survival to the general population. And when we use a dedicated device for that and the standardized remodeling route repair, we have a less than 2% reoperation rate at 10 years. I I put that slide because the course, I've organized the course with EACS this week in Paris. It's a little too late to come, but maybe next year you may want to come with live session and hands-on on human hearts to learn this standardized approach if you're interested. The objective is to repair as much as possible valves that are repairable. It's not to be extreme, an extremist, but it's just to adapt, I mean, to perform the techniques according to the obligation of the mean, which when the valve is repairable. Thank you very much for your attention.
Professor Lansac, thank you very much. That was really very good. I learned a lot, and you really are a leader in this field of cardiac surgery. I see there are some questions in the audience. I do have myself a lot of questions, but maybe we can start with the people in the audience. Ibrahim, you want to ask something?
Yes, thanks, Matteo, and thanks, Professor Lansac, for the very, very interesting presentation. So this technique, well, it seems it needs a lot of experience and talented surgeons, of course, but maybe for the young surgeons. So there's, of course, selecting the patient and selecting the approach. So you presented to us how you select which approach for which pathology, but for which valves would you say, of course, not calcific valves, but for which valves would you say, okay, for this patient, I will not try to repair it?
If the valve is calcified, is extensively calcified, I will not do it. It's with extensive fenestrations. If the patient is very old, with pre-ruptured fenestration in all the commissure, I will abort. But otherwise, I will try to go for it. And of course, if you're not familiar to this kind of surgery, it looks that there is a lot of detail, and indeed, there is a lot of detail. But if you want to go for repair and tackle the 80% of repairable valve, you need to be very, very standardized, very obsessional, if I may say. And that's dedicating. I mean, you cannot improvise. Once upon a time, one repair. You need to be very clear in your mind, and that's why the technique is based on the standardization of the root. The root is not an issue. Management of the root for an aneurysm, you will do always the same thing. There is no question on how high do you place the commissure, how you manage that, so you can focus on the valve, and that's very. I think that's the key. That's the key issue.
So you basically go for every, let's say, pliable
Yeah,
valve.
of course. Yeah.
As long as they don't have a large calcification, you try to repair it.
Yeah. If it's a localized calcification, I will decalcify it. If it's a calcified raphe, I will decalcify it. But if the valve is pliable, yes, of course. I think we need to have the same thinking as for the mitral. And I'm a little older than you, unfortunately, and I've seen a little more. And I've seen. I was the resident of Carpentier. I had a director of research of Carlos Duran, so the two fathers of the mitral. And they were struggling with a lot of people who were saying, it's an old patient, it's a bileaflet prolapse, we replace blah 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 blah. And still in some centers, still complex, what is considered as complex repair, surgeons will automatically replace the valve, which is not what should be done, but it is the reality. And for the aortic valve, it's also a matter of learning the techniques, getting into the logic of stepwise repairing all the valves that are repairable, and not taking decision a priori. You know what I'm saying? It's
Yes.
just like on the echo, this valve is not repairable. I mean, I've been trained as a mitral surgeon by all the big guys, and never, ever you take decisions on the echo. Never. You take decision when you analyze the valve. Carlos Duran used to say, play with the valve for 20 minutes and then see what you can do. And that's very true, because it's very important to be aware of surgical fear. We used to deny that fear, but it's a reality. And most of the time, one of the way to deal with the fear is to take quick decisions. But sometimes quick decisions means clack, 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 I cut the valve. And going stepwise, you see what you can do, and then understand, and then you make it one step. So you're not you start to repair what before you would have considered as more difficult, and you see that that it's feasible. But
Thanks a lot, Professor Lansac. Maybe one more question, because you mentioned, and as we all know, that the patients for the reimplantation technique were highly selected group of patients, and maybe if I understand a certain message from your presentation would be that this highly selection of patients for aortic valve repair, that's the concern that maybe young surgeons should learn at an early phase. So are you planning to compare the remodeling technique with ring to the reimplantation technique?
Yeah, there have been a paper published by Vincent Chauvet where we compare on the Marfan the different approaches, and there was no difference, reimplantation or remodeling with ring. There was the patients um, from Saint-Luc in Brussels, from El Khoury's group, from Schaeffer's group, from my group, from Montreal group as well, and I think a couple of others. And there were no difference. I think the problem is not the technique is I mean, the reimplantation technique is an excellent technique. There is no doubt on that. And doing a remodeling alone is a mistake. So the question is how many valve will repair. And as a matter of fact, SDS database where you have a lot of uh, reimplantation, mostly reimplantation. This may change because in New York and in many centers they start to do remodeling with annuloplasty, and this might change. Uh, uh, it, it's it's it, it's it it's a matter of getting above the 13% repair rate. The reality is that only 13% of the patients are repaired. And it's understandable. Most of the surgeons, they do eyeballing repair. So if they don't use the effective height caliper, most of the time standardization is tricky. Sometimes the graft is very much oversized by 2 size, 4 size. So the annuloplasty is not really there. I've reoperated cases of reimplantation where it was a problem. The annulus was not reduced enough. If you put a 32 graft or 34 graft, it's not always, it doesn't perform an annuloplasty, and you can re-repair those valves. I mean, it's just a matter of getting into the standardization. I think that's the key message. It's not a matter of which technique you use. I think going stepwise with a remodeling and annuloplasty, you can tailor your operation to the patients and not doing always the same operation. And for the patients, like doing a reimplantation in all cases, even if the root is not dilated. But that's you're good when you do always in the same way, so you can adapt to the specificity of each valve.
Thanks a lot. Thank you very much.
There is another question, Mickey.
Oh, yeah. Thank you very much, Professor Lansac. It was a very educative presentation for all of us. You have a major experience in this field. Obviously, the standardization of the procedure is helping quite a lot. Have to teach also other surgeons. My question is, in your experience, even if everything seems quite well, that you can put every patient on the standard scheme and give the according treatment, but there should be some limitations. For example, the age of the patient. You said almost all of the valves, most of the valves can be repaired, but even when you see that there's an old patient, the valve looks quite well morphologically, but it's an older patient. And what do you think during the surgery? You said, okay, if I do the repair and it doesn't work, and you just go for the second one or replace it, or what is the limitation?
What is an old patient?
This is my question for you. What is
no, but what do you consider as an old patient in terms of age?
75, 70, actually 70.
70. Okay. I would. It depends on the lesion, of course. If the valve is retracted, if there is extensive calcification, or if there is extensive fenestration, so more than one involved. If it's above 75, I will not go for it, or above 70 if it's in bad shape. But if the valve is nice, if there is no major, technical issue. So with a predictable results, I would go up to 80, like for the mitral. It's very rare because most of the time, but it's rare to operate patients at the age of 80. But at the age of 70, it's very common. And the problem is when you put a bioprosthetic valve, you enter other problems. I mean, of course, if you have a failure of your repair, it's a problem. But if you achieve a good result on a tricuspid valve, it will remain stable. And the probability that he has a problem on this valve is extremely low. Even sometimes I've seen patients 75 years old with pliable bicuspid valve, and I have repaired them because the rate of endocarditis will not be the same. You have less materials. The older you become, the more infection you will have. And we see all those patients. I'm sure you attend the endocarditis team. Of course, they will come out of the hospital with a nice functioning valve, but they will come back with endocarditis very often. And that's an issue. If you have the valve repair, it's like for the mitral. The probability to have a mitral endocarditis is not zero after mitral valve repair, but it's less. And it's the same thing for aortic valve repair. So that's why it's maybe because I feel bad when when I replace the valve. It's like for the mitral, I'll feel bad. I can't do it. I do it only when I'm forced to do it.
Okay, thank you very much.
No, you're welcome. But training is an issue, and we're actually comparing, proctoring versus senior surgeons. We have a paper ongoing on that.
Professor Lansac, I have a few more questions. I mean, I could talk with you about this topic for hours, but we don't have so much time. But the first one, you showed those interesting results about the fenestrations. It's actually no difference if you close them or not. What do you actually do? Do you close them?
After that, it was the thesis of Nathanael Schreier, Monier Schreier, and I tend to respect them more. And actually, having had the chance to work very closely with Jochen Schäfers and Jebrin El-Khoury, I saw them less and less touch the fenestrations. And so I was willing to have a scientific evaluation and compare and respecting a fenestration. So when the base is more than 1 millimeter, I mean, looks not in a pre-rupture state, is not involved in the prolapse of the cusp. If you keep it, it will not torn. It's there since birth. And so it's a good, it will remain stable. And so there is absolutely no indications to say, oh, there is fenestration, let's cut the valve, which is very often done, unfortunately, very often. And similarly with the insertion of the right ventricle, the infundibulum within the right sinus, you can dissect. It's a matter of learning how to do it.
Yeah. And you showed that flexible ring. Is it actually commercially available? Like, can we?
Yeah, it is. It is commercially available by Corneo. It's a Canadian company.
Okay.
They're very small. Well, we're trying to get a larger company to get involved into aortic valve repair.
Okay.
Because I think it's just that everybody participates, and if industry embark at a larger level into aortic valve repair, this will also help to increase the rate of repair rather than replacing the valve, because it's not the same life expectancy.
So for the sake of time, I have one last question. You showed very cool cases, let's say, but they were elective cases, I think. What's your experience with type A dissection or like emergency patients Do you still perform remodeling or valve repair?
I do. I mean, I moved to another center, and I'm not doing any more days on call, so I'm very lucky. But I used to do it on dissection cases, and my colleague Olivier Bouchot published on that on remodeling with ring on dissection. Actually, most of the time, at the level of the annulus, the aorta is not dissected. Only the commissure between the right and left is dissected. I can understand that it could be very scary to do a remodeling in case of dissection, and to my point of view, I think the reimplantation technique for the hemostatic issue might be a very safe operation, although when it bleed into with a reimplantation operation, you never know from where it bleeds. So it's it's also whereas in the remodeling technique, when it bleeds, you know where it bleeds. So you can most of the time manage, but I can understand that it is scary. Unfortunately, the problem is that it's also a problem of training, and that's why I'm very keen to have techniques that are very standardized and that I can help the young ones to learn how to do repair from the beginning. And the problem is that in most of the centers, as you know, I don't know how it is in Leipzig, but in most of the centers, it's the senior very senior surgeons who doing these operations on elective cases, and most of the time the young ones, they don't do it and it's very hard to learn it. So then you learn it on the most difficult ones, which are the dissections. Hopefully on dissections, most of the times there is no major valvular problems. So if you do a reimplantation or remodeling uh, most of the time without touching to the valve, it will be okay, and you will not have a residual regurg. But if you have a pre-existing valvular pathology, which you don't know because the patient is dissect and he has an AI, so you think that the AI is related to the dissection, but it might be also related to a dystrophic valve. Uh, if you don't manage properly the valve, you may end up with a residual regurg, which most of the time will be tolerated, but down the road, it will be an issue. So there come back the standardization of getting very routine on elective cases and apply the same routine on dissection cases. So I strongly recommend to check the free edge length, assess the effective height, even on the dissection case.
All right. I also saw you use the Valsalva graph, right? And I had a conversation with Tyron David, and he actually initially used the Valsalva graph as well, and then he came back to the straight graph. And actually have a publication with the team from Stanford together, and they have like a sort of ex vivo simulation, and they actually kind of demonstrated that the, let's say, the hemodynamics or the biomechanics within the sinus of Valsalva are better in the reimplantation technique if you use the straight graft. So I will be interested about what you think because you use the Valsalva graft.
Yeah, you know, nature, perfection of nature never make things by hazard. You know, if there is always a meaning, there is always a, and otherwise they will disappear with the evolution. And we still have sinuses of Valsalva. So I've done my PhD on that. I know very well that topics. And they're there. This was already described by Leonardo da Vinci. It still makes sense, and it's on most of animals. It's still there. So it explains the longevity of the valve down the road. After, when you do a reimplantation, if you use the Valsalva graft or any type of Valsalva graft, you have a problem. It's because the depending on the dissection of the subvalvular plane, depending on the height of the commissure, your commissure will not be at the neo-sinotubular junction. So most of the time, surgeons who do reimplantation, they address they cut in a circumferential manner the proximal suture. So you have it at a fixed stage, and then you have a neo-sinotubular junction where sometimes the commissure will not be high enough to reach the neo-sinotubular junction, or will be within the sinus. So this will end up to technical issues, where if you really listen carefully to um, uh, Jebrin El Khoury who is doing the reimplantation, is actually scalloping the proximal part of the graft. But at the end of the day, you don't know what annuloplasty you're doing, because you have having a very large annular base. So when you are an expert like Jebrin El Khoury, it's not an issue. But if you're not an expert, all those issues are potential problems. Whereas if you do a remodeling, this is not an issue. The three commissure will be at the same level. You reconstruct the sinus. The key thing is to avoid distortion. If you put the commissure within the bulging sinus and the other one at the sinotubular junction and the other one higher in the tube, then you will have issues. Then you have problems because you distort the valve. And that's the very good way to have a residual prolapse. So that's why. Then after that, Greg Miller and Tyrone David end up by saying that with an oversized straight tube plicate here and there, they are able to reconstruct neosinuses of Valsalva without a Valsalva. I would say it's an old battle. I've heard that for 20 years. They, with all the respect for those giants, I don't think this is where is the issue. The issue is the standardization, treat the annulus, properly position the commissure, properly resuspend the effective height. Have it very clear. That's the key for me.
All right.
I'm a little direct, but you know, at
No,
the end of the day, is how many valves do we repair? Because this is what matter for the patient.
yeah. No, thank you very much. And again, thank you for taking the time and for preparing the presentation and presenting it. We are very thankful. We learned a lot. And again, it was an honor to have you here. I hope to see you soon again. And
My
yeah,
pleasure.
yeah.
And and next year there will be a course in Paris. If you're interested, you're more than welcome.
Thank you. Yeah, sure.
And
Bye-bye.
send my regards to Michael.
I
Thank
will.
you
Yeah.
very much.
Bye-bye. Thank you.
Bye-bye. Thank you.